Hello, this is Albert. I'm here from Chicago, Baltimore.
Okay, thank you very much for that introduction, though I only heard part of it. Please repeat that.
Can you hear me?
Yes, now we can very clearly.
Okay. Okay, good morning, good afternoon. This is Sylvia Calvert from HW21 sitting in Baltimore.
Okay, thank you very much for that. We will now go ahead and just introduce the individuals. Oh, I see we've been joined at the venue by the mentors training that's happening at CIDAS under CDC. I'm not sure if Dr. Mwinga, can you go ahead and introduce the team?
Dr. Mwinga is in the back of the room, but this is Mary Boyd. So introducing the team from Southern Province and Eastern Province mentors at the venue. Thank you.
Thank you very much, Mary Boyd. Nefas, could you please go ahead and introduce yourself? Okay. Jenna, can you hear us? Are you able to introduce yourself?
Yes, I can hear you. This is Jenna Metz. I'm with HW21. I'm calling in from Baltimore.
Thank you very much, Jenna. Jackson Okuku, are you able to introduce yourself?
Yes, this is Jackson. I'm joining in from the CDC office in Zambia.
Thank you very much, Jackson. And we have Kanku Mukeba. Are you able to introduce yourself and where you're joining us from? Okay. Yuta, are you able to introduce yourself, Yuta?
Hello, everyone. This is Yuta Lima with Project Echo, also as part of HW21.
Thank you very much, Yuta. Just a quick reminder, we got feedback last time. We had some people joining in on names like admin or S8. It becomes quite difficult to get an introduction. Let's try to change our screens to something that's recognizable. If we are from UTH, we name the screen UTH. I've seen that we are joined by Dr. Mlenga. Are you able to introduce yourself, Dr. Mlenga?
100 kilometers of canals through here, and that kind of cut Scotland in two.
Dr. Mlenga, are you able to hear us?
So the next stretch of water.
Okay, we'll move on. Hi, Dr. Mlenga. Okay, we can hear you. How are you?
Hi, I can hear you. I'm fine.
We can hear you too. We are okay, thank you. Okay, we will now move on to Dr. Albert Mwango. Dr. Mwango, are you able to introduce yourself before I introduce the hub?
Yes, I'm Dr. Mwango. I'll be presenting on today's topic, the Zambia TLD protocols, transition protocols, and the drug interactions.
Okay, thank you very much, Dr. Mwango. We cannot hear you very well. Please try to move a bit closer to your speaker. So my name is Sombo. I'm here at the UTH Hub, and I'm joined by our team here from UTH. We have people from pediatric pharmacy. We have people from the adult pharmacy. We have people from adult center of excellence, pediatric center of excellence. We have Ahmed, who's from CDC. We have our IT team, and we have our infectious disease MMed registrars. Thank you all for joining us this afternoon. We'll go straight into the presentation. Dr. Mwango, are you able to share your screen with us? Thank you very much, Dr. Mwango. We can all see your screen. Please go ahead with your presentation. Sorry, Dr. Mwango, we actually can't hear you. Just hold on a second.
Can you get?
Mic is mute, yeah.
Yes, we can hear you very well now. Please go ahead.
Right. The presentation is going to focus on the Zambia TLD transition protocol and the drug interactions of dolutegravir. I'm currently the chair for the TLD Transition Steering Committee, which is a sub-technical working group of the Ministry of Health Technical Working Group. My position is Deputy Chief of Party Technical at CRS 390 project based here in Lusaka. I have no conflicts of interest or disclosures to declare. And I'd like to make a disclaimer that the views, thoughts, and opinions expressed in this presentation are solely my own and do not necessarily reflect the official policy or position of my employers, CRS, or the Ministry of Health Zambia, or the TLD Transition Steering Committee, which I chair, or any other group or individual. Errors and omissions accepted. Our learning objectives are two. The first one is to describe the TLE to TLD transition protocol. And the second objective is to describe drug interactions and side effects to consider when transitioning to TLD. A few acronyms which may pop up once or twice in the discussion. TLD represents tenofovir, lamivudine, and dolutegravir, a fixed dose combination of these three important drugs which we are going to be talking about this afternoon. And the new drug on the list is the dolutegravir 50 milligrams. The TLD is a fixed dose combination. Then there's TLE, which represents tenofovir, lamivudine, and efavirenz, another fixed dose combination, which we are currently moving away from as our preferred first line. And then there's TLN, which is tenofovir, lamivudine with nevirapine. DTG stands for dolutegravir. The background to this presentation is that early this year, we introduced in Zambia the Zambia Consolidated Guidelines, which are for prevention and treatment of HIV infection. And within those guidelines, TLD has been listed as the preferred first line. This regimen can be used in adults and in adolescents. It will be replacing TLE and TLN. And TLD is, like I mentioned earlier on, consists of a new drug which is coming on portfolio for Zambia, which is DTG. And this has been shown to be much more effective and more efficacious than efavirenz or nevirapine. We are also guided by memos from the Ministry of Health on how best to use this new drug. So why TLD? There are basically a number of reasons why. WHO, through Canters and colleagues, conducted a systemic review, and the major outcomes that were observed from this systemic review, which was comparing the efficacy of DTG to efavirenz 600 milligrams, showed a number of very interesting outcomes. Viral suppression at 96 weeks, DTG came out to be better. Treatment discontinuations were much fewer with DTG, came out to be better than efavirenz. CD4 recovery at 96 weeks after being on treatment, DTG came out to be better. Activity against HIV-1 and HIV-2, DTG was shown to be better. And then genetic barrier to drug resistance was also shown to be better for dolutegravir. In the areas of mortality, age progression, and severe adverse events, these were comparable between the two drugs. But one major research gap that remains is concerns regarding neural tube defects potential, which I think in the last couple of months since May have been quite of concern for a number of countries that are endeavoring to use dolutegravir. So this is an area which needs more information, and we are all, I think, globally looking out to studies that might shed some more light on this. Slide 8 is a polling question, the first one. Dr. Sombo?
Just give us a few minutes.
I can read out.
Please read it out.
Right.
Just read it out. It's fine.
All right. A 30-year-old HIV positive male on TDF, 3TC, and Rifampicin TLE has been monitoring viral load for more than 18 months. In the past 12 months, the last viral load was reported as less than 20 copies per mil. The question is he eligible for TLD? Yes or no?
Thank you, Dr. Mwango. You can just go ahead. I think the polling questions will be put up at the end. I think we're having an IT issue. Just go on.
All right.
We'll put them up again later. Don't worry.
Okay. Well, with that question, we'll now look at some of the materials that we have necessary for the TLD transition. First, we'll start with the transition protocol. On new patients, initiate all ARV-naive HIV patients on TLD as first line. This is the first guidance we have from the current guidelines. And this focuses on males who are 10 years and above and of a weight of 35 kgs and above. For females, this is directed for females that are 49 years and above and those of any age without pregnancy potential. New patients with HIV-1 or HIV-2 or a mix of HIV-1 and HIV-2 are also eligible for starting on TLD. Patients on first-line TLE or TLN that have been on these regimens but have not exceeded 6 months on these regimens are also eligible and are considered as naive for TLD transition. So that's for initiating new patients. For patients that are already on treatment, transition is based on them being virally suppressed. And these are patients who are on the first line of TLE or TLN. These can be transitioned to TLD. The key is that whether they're male or female, above 10 years, above 49 years of pregnancy, without pregnancy potential, they all need to be virally suppressed. Viral suppression is defined according to our guidelines as HIV-1 RNA less than 1,000 copies per mil. A viral load that has been done more than 12 months ago has to be redone. So this fresh viral load test has to be done for us to make a determination, even if it was suppressed. So this is basically our TLD transition eligibility criteria. There are some patients who don't follow these recommended regimens for one reason or another, but they are also being considered under the transition. So patients on TDF, 3TC with lopinavir as their first line, this could have come about because they're HIV, they are infected with HIV-1 or HIV-2 or a mix of these strains. They will be started on a lopinavir or PI-based regimen. These, because they are on first line, can be transitioned to TLD as their new first or preferred first line. There are also some children who are aging out from the pediatric regimens, such as ABC3TC with boosted lopinavir, abacavir, lamivudine with efavirenz, or AZT3TC with nevirapine. These can become eligible above the age of 10 years, especially the male children that are aging out from pediatric regimens. They can be started on TLD. Patients on AZT3TC boosted lopinavir, but this is being taken as second line, should not be transitioned to TLD. And why is this? This can pose a risk of keeping them on monotherapy DTG. We'll demonstrate this in the next slides. But first, let's look at the prescribing algorithm for males. We ask ourselves when we have a patient in front of us, a male patient in front of us, is this patient already on ART? If that patient is already on ART, we will want to find out what type of regimen they're on. Is it TLE? If it is TLE, we'll ask ourselves, how long have they been on this TLE? If it's less than 6 months, we can transition them to TLD. If it's been more than 6 months, then we have to have a viral load. And this viral load must show that they are suppressed. If they are suppressed, we can transition them to TLD. If they are not suppressed, then we have to manage them as suspected treatment failure. For any patient that is not on ART, they can be started on TLD. For females, the consideration of pregnancy has to be taken up, and we ask ourselves, is this female or this woman that is in front of us, is she pregnant? Is there a pregnancy test that shows that she's pregnant? If it is a positive result, then we ask ourselves, is she presenting on TLE or is she initiating during the first trimester? If she is, then we are recommended to consider giving TLE. If not, we ask, does she have plans for additional children, to have additional children after this current pregnancy? If the answer is yes, she's looking forward to having more children, again, we give TLE as a preferred choice. If not, we may have to consider TLD, but this is done with some consideration of what her family planning choices are. Does she have long-lasting, effective contraception, which should be given after she delivers? If she's not pregnant, the question is she of childbearing potential? Yes or no? If she's not of childbearing potential, for instance, she may have had a BTL in the past or a hysterectomy, some kind of sterilization, then we can safely give TLD without much worry. But if she is of childbearing potential, again, we ask the question, does she wish to become pregnant? If she says yes, the guidance is to give TLE as the preferred regimen. If not, then again, we ask, is she on any reliable family planning or contraception? And if she says yes, then we can give TLD, or after talking to her, we find out what kind of contraception she's on, and if we deem that is reliable, then we give TLD. If not, it's preferred to play it safe, and we give TLE. Polling question number 2, based on the same previous scenario. A 30-year-old HIV positive male on tenofovir, lamivudine, and efavirenz TLE has been monitoring viral load for more than 18 months. In the past 12 months, the last viral load was reported as less than 20 copies per mil. Why is viral suppression essential for TLD transition from TLE? We have 4 options there. The first option is it is not essential. The second option is to avoid iris. The third option, to avoid possibility of DTG monotherapy. The fourth option, reduce chances of hypersensitivity reactions.
Thank you very much, Dr. Mwango. I believe everyone has had a chance to look at those. You can move on. We'll put them up again. Don't worry about it as a polling question. I'm sure everyone has had some time to think about it.
Right. Thank you so much. Moving on. Detectable viral load is the first sign of drug resistance. I think this concept is very important to understand why we are insisting on certain things to be done as we are transitioning our patients. There are several causes of ARV treatment failure, but ultimately they all lead to having not enough drug or ARV in the blood. And this leaves a situation where the virus starts replicating in the presence of that small amount or insufficient drug level. This is a recipe for developing resistant viruses, and ultimately the patients may fail their treatment. And if we follow the red line, you will see that this is the first sign, that is viral load or being detectable. A viral load that is detectable is the first sign that the patient is actually failing treatment. It is only later that the CD4 count starts dropping and the clinical condition starts deteriorating. So viral load is the first sign of drug resistance. The following slide just basically shows what happens to a patient who is on tenofovir, 3TC, and efavirenz. Then they have a detectable viral load, which may be a sign of drug resistance coming out. Now, if that is the case, then it means that this patient has got resistance, which makes tenofovir, lamivudine, and efavirenz ineffective. So if we transition this patient who has got a detectable viral load, which may be a sign of drug resistance, then it means the patient will effectively only have dolutegravir as the active ARV. Tenofovir, 3TC may not be working. And effectively, this patient who we've transitioned because they have a detectable viral load, this patient is effectively on dolutegravir monotherapy. And what do we know about dolutegravir monotherapy? I won't go into this whole study called the DOMONO, which is dolutegravir monotherapy study. But the results show that this study was discontinued early because there was high VF, which is virologic failure rate, at 48 weeks of being on DTG monotherapy. There were two groups. The study group, which was taking DTG monotherapy, 8 out of 77 patients had virologic failure, compared to 3 out of 152 from the control group. These virologic failures are significantly different. So it goes to show that there are actually more DTG monotherapy virologic failure than being on routine ART, which is combination ART. So that basically tells us that DTG monotherapy will ultimately, within 48 weeks, lead to treatment failure. The other thing of note is these patients were suppressed to begin with. But here we have a situation, we are transitioning a patient who's showing signs of virologic failure. So it means they might even fail much earlier than the 48 weeks seen in the study. So to move on a little bit, how to take TLD and how to schedule it. The patient takes 1 tablet of TLD once daily, preferably in the morning. DTG is known to cause insomnia. Although this guidance and recommendation is being given to our patients, it is anecdotal. There hasn't been substantive studies that have proven that giving or dosing in the morning does have benefits, but this has been reported in over the 5 million people that are, 500,000 people that are taking TLD around the world. For ART naive patients, you give the whole bottle. There's a practice of opening the bottle and counting out tablets. That is not being recommended. Give the whole bottle and let the patient take the tablets over the period. The 2 weeks follow-up can be done even with the patient having a full bottle. The follow-up is also at 4 weeks after initiation, and then thereafter monthly visits of 2 to 3 months. If they're in a DSD, this is every 3 months or 6 months if they're stable.
For existing patients, again, we give the whole bottle and they'll take it over 30 days. They'll have monthly reviews for at least 3 months, or if they're in a DSD, it's done every 3 to 6 months so that we do not disturb their DSD schedules. During subsequent reviews, close monitoring for possible side effects and adverse events must be done. In the consolidated guidelines on page 39, we have a table that helps us do this. So, TLD use in special populations, what do we need to look out for? Based on the risks, potential risks of neurotube defects, we have to look at women of childbearing potential and adolescent girls who do not directly qualify for TLD in our guidelines. New patients on TB treatment, these should be initiated ideally on TLE, and then you switch back to TLD after they complete their anti-TB completion. For those on TLD who develop TB, there are some strategies that can be considered. If you have access to DTG 50 milligrams, we add that additional single pill of DTG 50 milligrams so that the patient is on TLD plus DTG 50 milligrams. So they are basically on DTG 50 milligrams BD. If DTG 50 milligrams single tablet is not available, then we have to switch to TLE for the duration of that treatment. But then there's some situations where patients were unable to take efavirenz before, maybe due to reactions to efavirenz, or they failed efavirenz. Then we have to switch to lopinavir boosted. For TB, we do not use atazanavir boosted. After they've completed the treatment, we can switch back to TLD. For lopinavir, just to note, this is not given BD as we usually do for TB. It has to be phased in at first 2 tablets BD, and then 3 tablets BD after a week, and then finally we give it as 4 tabs BD. You will note that this has significant pill burden. This is the algorithm we're using to guide for the prescribing in the case of where there is TB co-infected with HIV, and we have to provide TLD together with TB treatment. If the patient is already on ART, again, we have to ask if there's DTG available. If it is available, we can double dose. If not, then we have to use the efavirenz. If we can't use the efavirenz for whatever reason, then we have to use boosted lopinavir. Potential side effects. TLD consists of 3 drugs, and I think that's another important to really stress on. So we have to think of side effects as a result of all 3 drugs. Tenofovir is known for contributing or making worse kidney failure. It can cause bone problems, lactic acidosis, and other liver problems. 3-TC, one of the most tolerable drugs, still has some side effects such as headache, nausea, diarrhea, abdominal pain, basically GI upsets and disturbances in most, but not few, in few patients, but not most of our patients. It's a well-tolerated drug. DTG, which is just coming on the scene, is been known to show high levels of insomnia, but these high levels of insomnia does not mean that all patients will have insomnia. In fact, it's been shown that less than 5% of all patients who take DTG get insomnia, although it's one of the most common side effects of DTG. Other side effects, which we have seen so far at less than 1% since we started the rollout, is fatigue, headache, and we are yet to hear what the laboratory picture looks like on routine monitoring. Another possible side effect, which is of note, is iris. Dolutegravir lowers the viral load very quickly, and this is a predisposing factor for iris. So it is anticipated that we may have a few iris patients. All side effects and adverse events should be reported using the pharmacovigilance at ZAMRA. We are recommending that everybody be diligent in sending in these passive reports so that we can keep track of this new drug. In terms of drug interactions, most of the drugs cause DTG concentration in the blood to go down. And there are some strategies which are being offered here on how to handle that. If it's given with etravirine, the DTG must be co-administered with the boosted PIs listed here, lopinavir, tenofovir, and ritonavir. If it's given in presence of rifampicin, we have to up the DTG dosing by 50 milligrams from the OD to BD. Nevirapine has got significant reduction of DTG levels in the blood, so it should not be given at all. Try and avoid this combination. Phenytoin, carbamazepine, these anti-epileptic drugs can also give relief if somebody is failing to sleep. Please do not combine these with DTG. If a patient is taking antacids, laxatives, or any calcium ion containing combinations or multivitamins, try and time the giving of DTG strategically. Give the DTG 2 hours before or 6 hours after the supplements. If that's not doable, another strategy is to give the supplements with DTG and give with a meal. Metformin is a drug which is used for controlling glucose levels in the blood. This has been shown to raise the levels of DTG. So this may lead to patients, if given together with metformin, to have glucose unpredictable levels. So it should be given at a low dose. The metformin should be given at a low dose of less than 1 gram, and then monitoring the glucose to ensure that we find an opportune dose that will not cause severe change in the glucose levels. So these are some of the issues we need to keep in mind: the side effects, insomnia from the DTG, iris, how to treat TB, co-infection, the pregnant woman, which needs more studies to actually give us a definitive answer, and also how to dose in children. There are some absolute contraindications for DTG. It should not be given after somebody has experienced a hypersensitivity reaction to DTG. A repeat dose can be fatal. And also some antiarrhythmic agents should not be mixed with DTG. This can make the antiarrhythmic agents work in a detrimental way for the patients. So in summary, DTG is a potent and efficacious drug with very little side effects and drug interactions compared to other agents. It has a very high genetic barrier to resistance. Males and females, older children and adults can use dolutegravir-based regimens, in this case our TLD, and in some special considerations, even other women who have pregnancy potential can use this drug. Most drug interactions result in lowered DTG levels. For the polling questions, the 2 questions we had, the following are the answers.
Dr. Mwafo, are you able to just hide that slide quickly? I want to put up the polling question from here.
Okay.
Yes, thank you. Thank you. Sorry about that. We had the 90.
Right. Sorry.
Just stop sharing your slide so that I put up your polling question.
Got it.
Are you able to stop sharing your screen? Just, I think, stop it. Okay.
Yeah. Just give me a minute. Yep.
Thank you. Perfect. Here comes the polling question. We'll give everyone just a minute and a half because we are slightly behind time. We need to get into the case. Essentially, they are the same questions that Dr. Mwango asked, but our spokes are welcome to pour in and give us their answers on that before Dr. Mwango talks about what the answers actually are. We'll give you a minute and a half. I can't see any answers. Okay, there. Okay. Okay. Dr. Mwango, I hope you're able to see the poll, the way people are answering your question.
I am looking at it now. I can't see the answers though. He wants me to answer first.
Can you see yes and no there on your screen?
Yes, I can see the yes and no.
And then no. So those are the answers to your questions. Would you like to comment on that before I move to the next question?
No. I've only seen the question. You only sent me the question. I didn't get it. Sorry about that.
You're supposed to see that on the screen. Let me just ask Skype. Okay, I think you're the only one who can't see it, but I'll tell you what most of the answers are.
Okay.
So 91% have said yes to your first question, while 9% have said no. They feel the patient is not eligible for TLD. Any comments on that?
It would be interesting to know why they don't think so, because the 91% seem to be agreeable. Maybe they had a quick eye, but nonetheless, it would be interesting to know why they don't think so.
Okay, so the long and short is that the correct answer is the patient is eligible for TLD transition. Am I right or wrong?
The correct answer is this patient is eligible.
Okay, thank you very much. They are male, they are virologically suppressed, so they are eligible for TLD. I've put up the second polling question. I'll give our spokes a minute and a half to answer that question before you zero in.
Okay.
Apologies that you can't see their answers, but I'll tell you what they say.
Yeah, I can only see the question, the poll itself.
Are you able to see what's happening? Like how many people are saying 1, 2, 3, Dr. Mwango?
No, I can only see the question.
Oh, okay.
The poll itself.
Okay. I'll let you know what it says. Okay, so the answers that we have here for your patient as to why suppression is essential before you transition a patient, 88% have said
now
that. You can see now?
Yes, it's come up now.
Oh, perfect. So that's your answer. Any comments?
The hypersensitivity reaction was a red herring. But I think we got the message on DTG monotherapy, and I think that's the best response that I expected. 89% of everybody, that's a good response.
Okay, so the correct answer is you want to avoid monotherapy. That's why you want to make sure that the patient is suppressed. Make sure all the other backbone drugs are working. Thank you very much, Dr. Mwango. We will now go into our cases. I'm not sure if we'll have time for two, but we'll start off with the first one, which is from one of our doctors here at UTH.
Okay.
It's just about to come up.
Good day, everyone. I'm Dr. Mwansamwale here at the Adult Center of Excellence. I'm here to present to you the case of a 24-year-old female who was recently tested with HIV and actually has both HIV type 1 and 2. She came in for initiation of ARVs. This client has been on anti-TB treatment for extrapulmonary TB for 2 weeks and is taking 3 tablets of the fixed dose drugs. Therefore, she's in category 4 of the stage 4 of the WHO staging. She doesn't have a regular sexual partner and she's unemployed. On physical examination, her weight is 49 kgs with a height of 159 centimeters, making her BMI as 19.3. She had a temperature of 36.8 degrees Celsius, a pulse of 84, respiratory rate of 18 breaths per minute. Her blood pressure was 107/85. There were no abnormal physical findings. On lab investigation, what was to be noted was that her CD4 was 17 and an HB of 9. She didn't have any kidney or liver discrepancies. Our question regarding this case is, what best ARV regimen can she be initiated on, considering her medical history and paying particular attention to pill burden with regards to drug adherence?
Right.
Okay, thank you very much, Dr. Mwango. I'll just get an opinion from the spokes if they have any clarifications for Dr. Mwale, who has presented a 23-year-old female newly diagnosed with both HIV 1 and 2. She met her at 2 weeks into her ATT for extrapulmonary TB. Her question is, what ART should we initiate this lady who's 23 and already on ATT for 2 weeks? She's unemployed and has no regular partner. Our spokes, may we please have any comments or questions you may have for Dr. Mwale, who's taking care of this patient? You can even use the chat box to type in the question. Or you can raise your hand or use the icon for the arm raising. I have a lot of people in the hub itching with questions, but I want to give my spokes priority. Dr. Mlenga, please go ahead with your question. Dr. Mlenga, can you hear us? Unfortunately, we can't hear you. Are you able to use your chat box for that? While we're trying to set up with Dr. Mlenga, can other people ask questions if they have questions? Our clinical mentors at the Siders venue. I had a question. What is the site of the extrapulmonary TB?
This client was diagnosed with TB of the abdomen.
Okay. So it's actually TB of the abdomen. Do we have any questions from our spokes? Choma, please go ahead with your question. I'm seeing a hand in Choma.
We want to find out, was the viral load done?
No, a viral load wasn't done.
Why? Because in this area, I'm sure we should base for decisions of such cases on viral load. I want to find out the reason why the viral load was not done. And from the slide I saw you concentrated on CD4 count.
This client is not yet on ARVs. She came in for initiation of ARVs with a history of being on TB treatment for 2 weeks. So she came in for initiation, therefore we didn't consider doing a viral load at initiation. And so we concentrated more on the CD4 count.
Okay, thanks for clarification. Because maybe it's already on ART.
Thank you. Okay, do we have any other questions from our spokes? Anyone with a comment that the patient is on has both types of HIV? I can't see any hands from the spokes. So I'll move on to the hub. Oh, sorry, Dr. Mlenga has a question in the chat.
What is the creatinine level and clearance?
Can go back to the slide.
Dr. Mlenga wants to know what the patient's creatinine and the creatinine clearance is. So we are going back to the slides just to highlight what the creatinine was. It was 70, the creatinine clearance was 84.7 mils per minute. Any other questions from our spokes? So we're moving on to the hub. Dr. Mwemba has a question. Dr. Mwemba, please go ahead with your question.
So I wanted to find out when you say no regular pattern, what do you mean?
Yeah.
No sex or
any regular partners?
Well,
the microphone.
Am I loud enough? So I was asking what we mean by no regular partners. And then secondly, I wanted to find out if she's having, I see some sexual intercourse. Is there contraception?
The question that was posed to this client was whether she is married. She's actually single and doesn't have a sexual partner at the moment. Then she's not on any mode of contraception.
Chipata, please go ahead with your question. Chipata, please go ahead with your question. Okay, I'll go ahead and read your question, Chipata. The question is on the sexual history. Does the patient have multiple sexual partners or not? What is the history of pregnancy for the patient?
I believe I've already answered the question on the sexual partners. She's currently single and doesn't have a sexual partner at the moment. Then she's never been pregnant before.
Hi, Doug. We can see you. How are you? Hi, Doug. Can you hear us?
Yes.
Okay, I'll summarize the case at the end. Are there any other questions from the hub? Dr. Zico has a question.
Back on the issue of sexual partners, maybe we can just exhaust that. She currently doesn't have any sexual partners, but what has been her history with regard to sexual partners? How many sexual partners has she had, and how long ago was she involved in such activities?
She was in a stable relationship, but I didn't ask how far back that relationship ended. And I didn't find out how many sexual partners she's ever had.
Dr. Zico, why is that important? The question keeps on coming back. Maybe someone can tell us.
Okay, we would want to know the risk that this patient has. She's already infected, but this is a patient who can get reinfected and can also infect other partners. So we'd want to know exactly how her activity has been with regard to sexual activity.
Okay. Thank you very much.
attention, but it's the...
Sorry, Ahmed, I had put us on mute. Please start again.
Okay, so it's actually a potential question that can be added to the case if it's not already there. It's about the timing of giving ARVs, when to start ARVs, knowing that this patient has been on TB treatments for 2 weeks and that she has less than 50 CD4.
Okay, so Ahmed is just emphasizing that we need to pay attention. Her CD4 is 17, already on ATT for 2 weeks. Already we sent the patient home wondering what ART to use. It's something to think about as we discuss the case. Do we have any questions from our spokes? Zico, please go ahead.
What was the mode of diagnosis of the TB of the abdomen?
I didn't go into those details, unfortunately.
Okay, so before I hand the case back to Dr. Mwango, if there are people with questions, please type in or raise your hands. We can take them up, or if there are any comments. I'm going to summarize the case. We are presenting a female who's 23 years old with a recent diagnosis of HIV, both 1 and 2. Her sexual history is not very revealing. Apparently, was in a stable relationship before. I think we're unable to establish whether the man is from Zambia or from West Africa at this point. However, she denies having multiple sexual partners at this point. Her CD4 count is 17 cells per liter. She's been on ATT for the past 2 weeks. The TB is for TB of the abdomen, which is a presumptive diagnosis. It was a clinical diagnosis. Dr. Mwango, would you like to take up that case, or Doug, would you like to comment?
Sorry for joining late, but what was the evidence that she has HIV too?
The test result showed both HIV 1 and 2, the HIV test result.
Yeah, that's, there's a literature on this, including in Southern Africa, from South Africa and from Mozambique. And the upshot of it is that in this part of Africa, HIV-2 is rare enough that an HIV-1 positive rapid test and HIV-2 positive rapid test is most likely to be HIV-1 mono infection, and that the HIV-2 is a false positive, because there's enough cross-reactivity that some HIV-1 patients will show up positive on the HIV-2 test. And because the prevalence in Zambia of HIV-2 is so very, very low, that simply means that the positive predictive value that the HIV-2 test is low. That obviously puts you in a difficult situation, especially if the patient has tuberculosis. That's a difficult situation, and there aren't you don't have available a nucleic acid test that could distinguish between the two of them. This is not commercially available, so it's a very difficult situation. If the patient had been 1 negative and 2 positive, you might be a little more confident that she actually does have HIV-2.
Okay, Doug, I would just like to cut you short on that. I like what you are saying, but that there's a risk of cross-reactivity because our tests are dependent on having your positive predictive value. We have a high HIV-1 prevalence, so maybe the 2 becomes unreliable. However, as for the past 1 year, I think our tests can clearly distinguish between the 2. But let me get back to Dr. Mwango, who is aware, should have some information on some studies that have been done on HIV-2 in Zambia. Dr. Mwango, any comment on the prevalence of HIV-2, bearing in mind what Doug has talked about?
Yes, I think some years back now, I think 2 or 3 years back, we realized that we were getting a number of patients who were not responding well to treatment on first line with very good adherence. And our first line at that time was TLE. So there was an assumption that maybe our patients are failing because they've got intrinsic resistance to efavirenz. And that prompted a few investigators to do a few local studies. I'm aware of one which was made aware to, which Minister of Health got aware of. And it showed that when they were followed up with the standard testing, unfortunately, even the testing was just the standard rapid test, we had about 10% of that population that was followed up having mixed infection. They had HIV-1 and HIV-2. And then a proportion of that had HIV-2 only, which was much less than 3%. So with that, we, I think, determined at the Ministry of Health that we needed to be on the lookout for HIV-2. Having seen that we are neighbors with Angola and Mozambique, which have reported in the past of having HIV-2. And then, of course, travel has made it so much possible that our patients can pick up HIV from regions such as West Africa or other places where they have HIV-2. So the studies that were used were really small studies, which would, I think, do well to have PCR studies done as well. But we now have a test that can differentiate between the two based on its design. It can tell us who's got HIV-1 or HIV-2 or both. So we are cautioning on error with the hopes that we can be able to treat patients appropriately if they have HIV-2.
Very much, Dr. Mwango. I see Dr. Mlenga sent a message. He wants to comment on HIV-2 in Zambia. Please go ahead, Dr. Mlenga, with your comment. So what has come up from the discussion with Doug and Dr. Mwango is that when you get an HIV-2, you may not be able to tell if it's really a 2. However, studies were done in Zambia and we had 10% of mixed HIV-1 and 2, and only 3% had pure HIV-2. However, this was a rapid diagnostic test, so sometimes you may need to do further tests, which are maybe a PCR for HIV-2, and these are limited. I know when we talk about viral loads in Zambia, we are talking about HIV-1 viral load. So it's just something to think about in this patient. Dr. Mlenga, are you ready now? Dr. Mwemba has a question. Please go ahead with your question or your contribution, Dr. Mwemba. Dr. Zulu, you're welcome. I see Dr. Zulu has joined us all the way from South Africa.
So I wanted just to comment over the HIV-1, HIV-2. I think that obviously Bowline has had issues to differentiate between HIV-1 and HIV-2. And I think it's something that we need to take into account, that probably when we test these individuals and they're showing both tests, we need to confirm it. Because otherwise we'll be just treating people that are HIV-1 and then we're treating them for HIV-2 as well.
Okay, so Dr. Mwemba, I think, raises a point in the same line as what Doug is saying, that there is need to confirm HIV-2, but there are very few labs that can do that. I know in the past when we've had patients with HIV-2, we have to do the HIV-1 viral load here in Zambia, then send the other part to other labs. But I think, Dr. Mlenga, are you ready to comment? Okay. So the clinical mentors from Eastern and Southern Province who are here for their training, there's a question for Dr. Mwale, Dr. Mwanga, and all of us. Please go ahead with your question.
Thank you very much. I wanted to find out, since this patient has got a low CD4 count and has already started on a TB treatment for 2 weeks, is it very much a good so that we can do a liver function test to know at least the condition of the liver so that we can see which treatment that patient can be put on?
Yes, the liver function test was done and results were shown. I think if we can show that slide showing the results, please.
Okay. So I think what the mentor is saying, I must mention when we speak, we need to introduce ourselves so that we can address you by name, is concerned about the liver function test. I think what Dr. Mwale is saying is that the baseline was actually normal, but indeed there is need to monitor for toxicity in all patients on either ART or ATT. So Dr. Mwango, we will now throw back the main question to you. So I hope we can see what the ALT was. It was 23. I think that's millimoles, but was normal at that point. But I think we do need to repeat it. Thank you for that observation. Dr. Mwango, are you able to now comment on what regime we should go for in this 23-year-old woman?
Yeah. To come out is to identify the elements that would make us come to a decision. This case study requires that we observe all the different issues that are necessary. Here we have a 24-year-old female, and the guidance is we need to look at what we can use, what is available. What the preferred line is TLD. Now, this is a 24-year-old female who is severely immunocompromised and has got extrapulmonary TB. And assuming that the diagnosis of HIV-2 is still valid, what options do we have?
Sorry, so at this point, we will presume that this patient actually has 1 and 2, because this is how far we can go in our setting. So thank you for that, Dr. Mwango. You can go ahead.
Right. So we assume that this patient has got HIV type 1 and type 2 and not yet on ART. So this is a new initiate, only for viral load. They can have skyrocketing viral loads. It doesn't really matter. We're looking at a patient who needs ART treatment. So the question is, can they take TLD? Strictly speaking, according to our guidance, we should not give this woman TLD. It may be questionable as to whether her condition warrants her to be considered as the pregnancy potential or not. But strictly speaking, with the guidance that we have, this woman should not be on TLD. Now, if she has HIV-2, that also removes us from the option of using TLE, because the favorance is inherently resistant to HIV-2. So it has no effect on the favorance. So our options are now diminishing. We now have to look at the other options, which is the PIs. If we are looking at the PIs, we are talking about lopinavir. We're not going to use in TB atazanavir boosted. We're going to be looking at lopinavir. But then comes in the big question of the pill burden. She's already on 4 FDCs. If we introduce the full dose of lopinavir after the running period, she will ultimately be on 3-tab BD, 4-tab BD after the 2 weeks, which means she will actually be taking 8 lopinavir tablets. There will be tenofovir lamivudine, 1 tablet, and the 4 FDCs. So the pill burden becomes very high. That is the best recommendation in terms of the agents that we have available for her in line with the guidance.
Okay, so
the big question, will she add higher if we give this kind of regimen? She's already been on 2 weeks of TB treatment, which is good. And if we can't waste time in terms of waiting for her to finish her 4 FDCs, we have to introduce the ARVs. So ultimately, we have to contend and work with how best we can cope with the high pill burden.
Okay, thank you very much. Dr. Mwemba, would you like to comment on what we should do with this lady? There's the option of giving her the TL plus the lopinavir, which will be 4 tablets twice a day. That's about 8 pills in the morning, and she'll be taking about, I think, 4 in the afternoon.
I think
comment on what we should do with this lady?
I think for me, I would love to make it as simple as possible. And I think the simplest I can go for her, if we're assuming that she also has HIV-2, is TLD. And the reason for this is that I think the TLD will be temporal in her. We're not going to give her for too long. So all we need is to ensure that We counsel her that she should not get pregnant, and we do pregnancy from time to time just to make sure that she doesn't get pregnant, and we give her good contraception, and then she's able to complete her TB treatment, and then we can change her back to TLE.
Since you're talking about pill burden, sorry, how many pills will she be on if she's on TLD?
She'll be on
ART.
So ART, she'll have one in the morning, one in the evening.
So the 50 milligrams will be separate, isn't it?
Yeah.
I need to go back to Doug, but I've got a message from Dr. Mlenga, which says the viral suppression study that was done in Zambia showed an HIV-2 prevalence of 4%, and they confirmed this with a NAT. So we are somewhere between 4 and 10% in terms of HIV-2. So there are two options. We either give alopinivar or the DTG, we add the 50 milligrams. I think why Dr. Mwale is here, she's concerned about the pill burden. Doug, would you like to zero in on what we should do? Because our guidelines state that we need to give alopinivar, because she's a woman of childbearing age.
Yeah, I agree with the second option here quite a bit. I think we should not overblow this dolutegravir risk. Obviously, the data from Botswana is very concerning. So far, it has not been confirmed with additional numbers yet, but we just don't have large enough numbers. So yes, it's a theoretical but low risk. I agree that double dosing Kaletra is, and trying to treat tuberculosis, is just asking for trouble. And I think we should remember, if we're going to look at deleterious effects of drugs, the Kaletra's got a lot of them. There's a reason why we don't prefer it anymore. There's a reason why we use efavirenz instead, and then now use dolutegravir instead. So I think, and if she does become pregnant, one thing we can say, I think we pretty much set in stone, is we know that patients who are on Kaletra are more likely to deliver prematurely. Whether that effect occurs with other drugs or with ART in general is not clear, but there's been, confirmation of that observation, actually first made in Botswana. So I would have to go with the BD dolutegravir as for all the reasons dolutegravir is great. I know this is a woman of reproductive potential, but quite frankly, also there's a lot of reasons why we should try to avoid pregnancy in this woman as it is.
Okay, so there's, thank you very much, Doug. So there's the option of avoiding pregnancy and giving her the TLD plus the DTG, just because the pill burden is less. However, just to zero in on the case, in case there are people who didn't pick it, people are concerned about DTG in a 23-year-old woman because it has been linked to some neural tube defects and encephaly. So there's been some interim guidance that we should avoid it. That's why this case is quite interesting for this lady. And I know Dr. Mwango said we go for lopinivar because at the moment, DTG is only available at UTH, the loose DTG. So that's maybe something we need to think about. So I think Melody from the pharmacy has something to say. Please give her the microphone.
Hello, I wanted to say it's not only available at UTH, but in all advanced treatment centers, that is Livingstone Central Hospital, Lola Teaching Hospital, as well as ADH.
Yes, Amit, please go ahead.
I think this or not on taking it, and explain if she's going to be on birth control or not. And there is already a good indication that she's not going to be pregnant because based on the information you gave in the beginning, she doesn't have any partner at the moment, but doesn't exclude pregnancy. But consent and explanation and awareness can help solve this case. And I'll go for the second opinion also. I think the guidelines are clear, but expert opinion also is allowed based on clear indications.
Okay, I like what you said, Ahmed, at the end, because there's a message here that this is one of those cases where you call in for expert opinion. Do they have DTG available or not? Because it's one thing to want DTG and not have it. But there's a request if you can repeat yourself, the first part you said. I think what you said is that we need to give this woman full information. Yes, she may look like she won't get pregnant today. Tomorrow she may come back pregnant. We see it at a CD4 of 1. So I think Ahmed is emphasizing that we need to tell her there's this risk. It's actually not confirmed. They've just been linked. It's still being studied, but in the interim, we need to be careful and give women the full guidance. I know the clinical mentors have a question. Please go ahead with your question.
Sorry about that. So someone actually already asked the question that I had, so I'll hold it for now. The second question that I had is, can we discuss what options of contraception would be available in Zambia for this young woman, just so that if anyone else is listening, we can feel comfortable with what's available for this woman who would be best to be on TLD.
Okay, would somebody like to comment on the contraceptive options for this lady? So there's a comment from Sister Phoebe.
I think maybe we may give Desjardins, which is a 5-year contraceptive method. So with that, would be very comfortable that she wouldn't be pregnant.
Okay, so there's an option of the Jadel, because I think the issue is what are the drug-drug interactions? What do we have? What are options? I'm sure we don't want to sterilize her. I'm not a gynecologist or obstetrician, but I know that's not an option. Dr. Mwango, would you like to zero in on contraceptives and their interactions?
Right. The hormonal contraceptives do not have any known interactions with DTG. So, and even with the other components of TLD, there is no contraindication to using the hormonal contraceptives. So that means it's a matter of looking at how long the contraceptives would actually provide protection for this woman. So that's an option that would have to be taken up as to what is effective and what is effective on a long-term basis. There should be no concern about interactions between contraceptives and TTG.
Okay, so in summary, all available drugs can be given for this lady. There's no risk of interaction. There's a question from Dr. Mpeta. Please go ahead with your question.
On the same. First of all, I'd like to agree. That's it.
Comment from Dr. Mpeta, the topic at hand.
Yeah. So first of all, there are no interactions, drug interactions. Okay. You wouldn't want to give the oral. Oh, sorry. I've been asked to restart. I would like to agree that there are no drug-to-drug interactions with any contraceptives that are available in Zambia. But even amid this repertoire of contraceptives, we have to look at the question at hand, which is the pill burden. So definitely one would not want to give the oral contraceptives. And apart from that, even their reliability. The second, of course, you'd want to, this is a 24-year-old woman, probably would want to, for pregnant anytime. So we have to balance, okay, in terms of the duration of the contraceptive cover versus, the potential for pregnancy. So I wouldn't go for something that is very long-term. And I think an injectable in this case would be better. A 3-month, depot would actually be preferred, meaning that she receive twice, during the treatment with TB. So, and that will be short enough and will give them chance to fall pregnant. The other question, I think, was about the choice of DTG versus lopinavir. Of course, we would agree here, and we agree that DTG is the best option, and especially that we are looking at the pill burden. One of the questions I was asked, I think, when I interacted with a lot of providers is that what should one do that even after providing information about DTG, and then a woman uses it, falls pregnant, and has got an adverse, outcome of pregnancy, and then you get sued. Secondly, most of the centers, of course, operate on guidelines, and the fact that when they work outside the guideline, there's always, a coding that they receive from program managers. So what should they really do at the facility level when faced with such a question, and especially if there's a potential of a lawsuit?
Okay, thank you.
Before I say what I said,
okay. Unfortunately, we will not be able to take that up because we have actually run out of time. This was so interesting. However, I think the basic take home for this patient is that because you have access to dolutegravir, feel free to go ahead and use it because you've gotten the expert opinion. However, we need to make sure that she doesn't fall pregnant during this period, and maybe put her on an injectable contraceptive or Jadel, and then maybe after 6 months you may reconsider this regime to something that is safer. We need to bear in mind DTG, the loose one, is only available at ATC, so you may want to discuss this with them if you cannot use lopinavir. As for the other question on when we should initiate ATT, the fact that our CD4 is 17, at this point we have to, any studies have shown that a CD4 of less than 50, you need to initiate ATT as soon as ART within the first 2 weeks. So it's time for her ATT. I think Ahmed, that was the question. I think we can wrap up now. I know, Doug, you have something to say, but you can hang on. I know we will be discussing TLD several times here because we are in our transition, so we can move our ideas to then. Otherwise, thank you very much for your patience, and we'll see you next Monday. We are going to talk about pediatric ART. Doug will need you for that. Thank you very much, everyone.
Thank you.
Thank you.
Thank you.